Great. So thank you, obviously, for the introduction and to the rest of the group, including all the people in the background that really helping keep this grassroots effort to bring important information to Albertans going. So for those who are watching in our first week of these briefings, I presented some information back then on airborne transmission and how it relates to the COVID-19 pandemic. And I tried to identify a few of the sort of best practices that people can use to help mitigate transmission in different places. The basic idea boils down to us evolving our understanding of how this disease transmits from person to person. Last year, we were quite worried about surfaces and disinfecting everything that we were touching. But now we know that we need to be more concerned with the air that we're breathing. So as such, we'll be talking today again a lot about aerosols. And just as a quick reminder, a useful mental model to think about how aerosols behave is actually cigarette smoke. So what I'd like to do today is dive into a bit more of the science behind why we're very confident that we need to take airborne transmission more seriously. I'm very glad to have the other panelists here as well, and they've got some fantastic information to provide from a few perspectives that have been underrepresented during this pandemic. So my aim in the next few minutes is to really set the stage for them by showing that we really do have a huge amount of evidence that airborne transmission is important with this disease and that we should be reevaluating certain aspects of what we're doing. Next slide. So one area that has led to an immense amount of confusion has been over the role of droplets versus aerosols in the transmission of SARS-CoV-2. Early on in the pandemic, it became very clear that experts from different backgrounds were describing these things in completely different and inconsistent ways. So let's first clarify what we mean when we talk about droplets. Droplets are basically big, heavy blobs of liquid that fall very quickly to the ground. So when somebody coughs or sneezes, they produce some of these big droplets and they can expel them with considerable speed. Droplets themselves are quite big, with diameters greater than something about 100 micrometers. And this is similar to the width of about a human hair and is actually visible to the naked eye. So as such, they're relatively easy to detect without specialized equipment. Now, being so big, they have a lot of mass, and gravity pulls them down out of the air very quickly. So these droplets tend to travel ballistically. They kind of move like spitballs or like cannonballs. Now, if you're facing somebody who is coughing or sneezing and they're within a few meters or so, some of these droplets might manage to land directly onto mucous membranes like the eyes or the inside of your mouth if you're yawning or talking or something like that. But the droplets are actually so large that they can't really be inhaled into our respiratory tracts. They aren't nimble enough to actually navigate the bends of our nostrils or the back of our mouth, and so they don't make it into our airways. So when we're talking about droplets, we don't have to worry about inhaling them. So how do you prevent your exposure to droplets? Well, this is where the idea of droplet precautions actually come into play. The essential idea is to place a barrier between your mucous membranes and the person who may be coughing or sneezing directly towards you. By doing this, you're preventing those droplets and any virus they might contain from actually reaching vulnerable tissues on your body. Now, droplets do not move around corners and they fall to the ground very quickly. So putting distance between you and the person who is coughing or sneezing is really going to help reduce the odds that a droplet is going to move on that perfect trajectory that would end up with it landing in your eyes or in your mouth. Next slide, please. So what about aerosols? Well, aerosols are smaller bits of matter that tend to float around in the air for more than a few seconds. They're carried around by air currents and they respond very quickly to changes in the wind or flow of air around them. And because they're smaller and much more nimble than droplets are, we can actually inhale them into our respiratory tracts. And depending on their size, these aerosols can penetrate deep into our lungs, where they may actually end up landing on the inner surfaces of our airways and inside of our alveoli. And as a rule of thumb, we usually think of aerosols as having diameters smaller than something at about 100 micrometers, since particles smaller than this size can remain suspended for a few minutes to hours. And I do want to clarify that there isn't really an exact delineation between droplets and aerosols, but this 100 micrometer size range is a reasonable approximation where the ballistic behavior that we tend to attribute to large droplets starts to transition into this more floaty behavior of aerosols. So those things that will tend to stick around in the air for a little bit of time. Next slide. So now that we've better described what aerosols are, we have to determine if they're actually important for the transmission of disease. One of the first questions we have to ask is, do people actually generate these aerosols? And the resounding answer is yes. And in fact, we produce a lot of them. But these aerosols are so small that they're almost impossible to detect or to measure accurately without the use of specialized equipment. So this isn't really a case of holding a plastic bag in the air and thinking that you'll be able to get an accurate measurement or capture aerosols that you're concerned with. You need to know how to measure these aerosols if you actually want to measure them. So fortunately, we've had a lot of really great studies come out in the last year that have utilized appropriate instrumentation to look at how much aerosol people are producing during different sorts of activities. And a good example of this sort of equipment is kind of shown here on the bottom left. So it turns out that even during normal activities like talking, exercising, and shouting, we're producing far more aerosol than during some of the medical procedures that have been traditionally considered as aerosol generating. So what this means is that even without aerosol generating medical procedures, people can be producing a lot of aerosol. So we now know that people are essentially constantly producing aerosols, and that they can produce a lot of aerosols when we're doing things like singing, shouting, coughing, and even talking. Next slide, please. So the next question is whether these aerosols can contain infectious virus. And again, the answer is yes. So the bits of matter that we emit as aerosols are actually made up mostly of respiratory fluid or saliva, but they also contain anything that is inside those fluids. So if you're infected with SARS-CoV-2 and you're actively shedding virus, your respiratory fluid and saliva will contain SARS-CoV-2 viral material. And this is actually what we rely on to diagnose infection with SARS-CoV-2, the presence of viral material in saliva or respiratory fluid. So if our actively shedding person generates aerosols when they speak, cough, talk, whatever, some of the aerosol that they emit is going to contain virus. It's not a case where every single aerosol particle is going to contain an individual or multiple viruses. And in fact, many of these viruses won't contain, or many of these aerosols won't contain any virus at all for the typical sorts of concentrations that we're observing in these fluids. But some of these particles absolutely contain viral material, and several studies have now successfully cultured infectious virus from air samples taken near COVID-19 patients. The infectivity of these virus-containing aerosols has also been well demonstrated in a number of different animal studies that have clearly shown transmission occurring through the inhalation route. And I want to be clear that the evidence that we've gained since the start of this pandemic in support of inhalation as an important route of transmission is frankly overwhelming. We have more evidence for inhalation playing an extremely important role in the transmission of COVID-19 than we do with essentially any other disease. And this includes classic examples of airborne diseases like measles and tuberculosis. Now, various researchers have done an absolutely incredible job amassing this evidence and in fleshing out this framework of disease transmission. And what I think this knowledge is pointing us towards is that aerosols are playing an important role, not only for COVID-19, but for respiratory diseases and transmission in general. Next slide, please. And just to reiterate the point that there's a lot of evidence in support of this, this is just a partial sample of a number of the various papers that have demonstrated some of the critical elements that are pointing towards inhalation exposure being very important. Inhalation exposure is something that's occurring both at short range and at long range. It's something that is explaining the preponderance of pre-symptomatic and asymptomatic transmission. It's something that's also explaining, the presence of viral material on various no-touch surfaces that has been observed time and time again in different patient rooms. So this is a consistent framework that is absolutely based on the evidence, and we need to adapt our policy to consider it more directly. Next slide. Now we can start to describe some of the things that influence transmission through inhalation. So first of all, it's important to recognize that aerosols spread from the source, and they're most concentrated near the spot of emission. So this means that inhalation is important both in close proximity to others, so within about that 2-meter distance that we've seen used so often, and across longer distances, particularly when ventilation is suboptimal. And on that note, determining if ventilation is suboptimal is something that needs to be performed by qualified professionals who understand what to look for. In Alberta, this would be licensed engineers registered with APEGA that follow the up-to-date guidelines from ASHRAE and that recognize the importance of airborne transmission. Now, the actual risk of you becoming infected from inhaling viruses relates to the amount of aerosol that you're exposed to. Factors that affect this include distance to the emitter, includes the time that is spent sharing that same air with them, the number and type of mitigating layers that are in place, the amount of virus that is actually being emitted by the person who's infected or the people who are infected, and various environmental conditions. So needless to say, this is a complex problem, and there's a lot of statistical elements here. But despite that complexity, we know that to reduce the risk of infection, we need to reduce our exposure to infectious aerosol. Next slide. And just to remind viewers about mitigating transmission, the key to mitigation is in recognizing that, while no single layer of mitigation is perfect, we can vastly reduce the risks of transmission occurring when we layer up multiple individual actions like physical distancing and masks, together with shared responsibilities, like the good testing and tracing, improved ventilation and air filtration, and widespread vaccination. We can also look to improve individual layers themselves to make them more effective, like moving from masks to respirators, which is something that the other panelists today are going to be talking a lot about in depth. Next slide, please. And one complicating factor that has really made things hard to keep control of has been the emergence of the new variants. We've seen that some of these variants are actually much better at spreading from person to person. And a recent study concluded that this is partly because SARS-CoV-2 is evolving toward more efficient aerosol generation. So this implies that if we want to keep a handle on transmission until we're absolutely sure that we have sufficient vaccine coverage, we need to be using layered controls and tight-fitting masks and respirators to reduce inhalation transmission. And this increased transmissibility of variants is very clearly demonstrated by the Delta variant, which, as we've observed here in Alberta, can spread extremely easily in the absence of adequate public health measures. And next slide. And finally, I just want to highlight how there is a disparity in approaches to the default precautions that are used with healthcare workers and COVID-19 patients, depending on the jurisdiction you're located in. So in Alberta here, the default precautions are actually contact and droplet, where N95s are only to use during if these healthcare workers are performing a specific list of aerosol generating medical procedures, or if deemed necessary following a point of care risk assessment. This is actually in quite stark contrast to, for example, the CDC, which recommends respirator use during any interaction with suspected or confirmed COVID-19 patients. And I think we really need to question why we aren't using this sort of precautionary approach here in Canada. And as has been discussed by some of the very excellent infectious disease practitioners in the United States, we should consider the universal use of respirators in acute care settings when we have community transmission as high as it is, currently in Alberta. So I'll end it there, and thank you for your attention. And I hope this serves as a good bit of introduction for the remaining discussions from the rest of the panel today.